Good morning and good evenings, all my friends in ICC. We are so happy to have you today. Today, I am Dr. P.Y. Cho, and I am my partner, Dr. Junior Tu, will co-moderate this webinar. We are so happy to have Professor Anand Marya to be our special speaker today. Professor Anand Marya served as the Deputy Dean of Dentistry Research and the Postgraduate Director for Orthodontics at the University of Pusiantra in Phnom Penh, Cambodia. He is a distinguished academic and researcher with a focus on advancing orthodontics practice and dental science. Dr. Marya has an extensive publication record, having authored numerous articles in peer-reviewed international journals and edited several notable books, including Contemporary Orthodontics, an evidence-based approach, and Salo-endoscopy, a new horizon in the management of saliva gland obstructive diseases. His research interests are diverse and covering topics from orthodontics materials and public health dentistry to the use of technology in dental education. As a leader, he is dedicated to fostering an evidence-based research-driven culture. He plays a crucial role in mentoring the next generation of orthodontic specialists and elevating the standards of dental research and clinical care in Cambodia and the wild Southeast Asian regions. Today, Professor Marya's topic is extensive airway analysis using the machine learning. And by the way, we still have three world-class, very famous panelists will come join the panel discussion. Let me introduce one by one. The first one is Professor Clement Lin. Chang Lin is currently the head of the Plastic and Reconstructive Surgery Department, Chang Memorial Hospital. Professor Lin received his MD from Taipei Medical College and his master's from the Graduate Institute of Dental and Craniofacial Science, Chang University in 2007. His research interests are craniofacial development, growth and deformation, and craniofacial surgery in obstructive sleep apnea. He has many professional affiliations and membership at associations such as the Surgical Association of Taiwan, PRS, and the American Cleft Palate Association, and APCA as well. He received a research fellowship from Professor Christian Gillerman, Stanford University Medical Center, Sleep Center, from the 2009 to 2010. Our next professor is Professor Gung Cha. He's a distinguished professor of orthodontics and the Vice Dean of Academic Affairs at the Yonsei University College of Dentistry, South Korea. With a specialization in orthodontics complete in 2002, Professor Cha has held visiting professorship at the prestigious institutes such as the University of Southern California and the Stanford University. Professor Cha is an influential figure in the orthodontics community, serving as Secretary General of the Korean Association of Orthodontics and a board member of the Korean Academy of Sleep Dentistry. His research focuses on the CAD/CAM technology, and he has contributed significantly to clinical guidelines and published extensively in leading journals. And the last one, Professor Pirapong Santitwon. Professor is from Thailand, is the head of the orthodontic department and the program director of the Master of Sciences in Orthodontics at the Mahidol University, Thailand. Professor Pirapong holds a PhD in dental science from Tokyo Medical and Dental University, focusing on growth-associated protein changes in jaw muscle spindles. Additionally, Professor earned his Doctor of the Dental Surgery from Mahidol University and is a diplomate of the Thai Board of the Orthodontics, demonstrating his expertise in this field. And he has many contributions to the Orthodontic Society in Thailand. Now it's time for Professor Marya's presentation. Can't wait to learn and to listen to your great talk. Professor Marya, please.
So thank you so much, Professor Fang Yun Chao, for first of all for the invitation. I'd also like to thank Dr. Junior To and the esteemed panel members for this evening, Professor Clement Lin, Professor Jang Yulcha, and Professor Pirapong for taking out time from their busy schedules for uh, attending this session as chairs for this evening. So may I share my screen, please?
Yes, please.
Yes, please. So the topic that I wanted to discuss today was a little bit about upper airway assessment, and then I'll talk a little bit about how we face problems with the current methods of examination of the airway. How does it correlate to our work as orthodontists, and eventually my area of research, which is trying to find out different AI-based solutions, specifically for upper airway assessment. So again, thank you so much for having me. So a little bit about my background. I'm originally from Dehradun, India. So it's based in the north of India. It's a beautiful city with five seasons. We have different kinds of fruits. We have different kinds of weather. We have snow in the winters. It's very popular for water sports and for winter sports. So it was initially built by the British, and it's still very green with over 40% forest cover till today. And I've been fortunate enough to study at some of these schools and gain very valuable education, which is what has brought me uh, to where I am today. So I'm very thankful to each one of these schools for imparting me education, and always thankful to all my supervisors as well as advisors. So a little bit about my these are some of just an overview of my qualifications. I'm affiliated with these organizations. So specifically, a permanent member of the Cambodian Association of Orthodontists, the WFO, and associated with the AAO and the IOS. I'm currently based in Cambodia, which is located in Southeast Asia. It's a culturally very rich, diverse city with lots of beautiful scenic destinations to see. So for those who haven't visited it, I would always recommend. It's got something for everyone looking for a bit of travel, culture, heritage, very nice scenic destinations. And our university as well as office is located right here. This is just an overview of Phnom Penh, and we are located almost in the center of the city, just below the arrow. So you can see again, Phnom Penh is a very vibrant city with a lot of with a mix of tradition as well as modern construction, which is again I think this picture always reminds me of what I'll be talking a little bit about today as well. A little bit of tradition versus modern methods of upper airway assessment. So this is our latest digital health center, which just opened about a year and a half back, which is fully laced with 3D printing facilities, with digital scanning, CBCTs, and we try and keep in line with all the international standards that we can keep up with. And these are some of the journals that I work with. I've been very fortunate enough to work with some of the well-known journals, uh, mostly tier one. And this also keeps me up to date with different kinds of research which are going on around the globe. So these are some of my research rankings from last year. So we'll look forward and see how these turn out to be this year. So again, uh, coming to the topic that I wanted to discuss today, which is understanding the upper airway and sleep apnea. So again, I think what I wanted to essentially cover is a little bit about the upper airway, since sleep apnea has become, it's always been a controversial topic whether we should treat this, who should be the one treating it, who should be the one assessing it. But I think as healthcare professionals, we can all play a part in at least diagnosing or reaching a point where we can get these patients to have some form of treatment. So keeping that in mind is why I thought of talking about the different diagnostic tools available and what should be the approach, keeping in mind the access to AI we have currently. So I think one of the major challenges I've always seen in a lot of research which has been done is taking the airway as a whole or looking at a multi-dimensional problem from just a single perspective. So, for example, some things are only focused on fluid dynamics, some are only focused on clinical examination, some are only CBCT based studies. So, which is where I think the entire problem arises because we tend to look at a problem which may have differentiating factors, but we are always trying to approach it from one single way or with one single approach. So again, I think just to give the audience for those who are not aware, so again, sleep apnea is a problem which is found increasing prevalence worldwide. So it's caused by temporary occlusion of the upper airway several times during the night, which can lead to hypoxia and sleep fragmentation. So I will also, as the presentation goes on, talk a little bit about the post effects of this problem and why it should be treated or we should be referring somebody to treat these. So, as I just mentioned, the upper airway is a complex tube, as you would like to call it. So, it's a complex collapsible tube which has very specific anatomical boundaries. We demarcate this into different areas from the nasal cavity, the hyponaso-oropharynx, and then we also have structures which are key structures which are based in and around these anatomical boundaries, and these can different variations of these problems can cause airway obstruction and different kinds of sleep apnea patterns. So these are just some of the problems which I can list, which is nasal obstruction. I'm only going to focus on the upper airway, even though the complete airway is a big structure. So nasopharyngeal issues, oropharyngeal problems, laryngeal abnormalities. So again, if you just look at this closely, this itself tells you the extent of the problem, which is four different areas. We've always treated them as a single area of study specifically, whereas each of them can have their own pathologies which could cause different levels of OSA. It could be because of problems in the nasal cavity, problems in the nasopharyngeal region, the oropharynx, as well as the hypopharynx or the laryngeal region. So, talking about some of the factors now. So, because as I mentioned at the start of the presentation, there are so many predisposing risk factors, out of which let's just take them up one by one. So we have the first factor would probably, just to name one, would be just talking about the BMI. So again, um, we have different ranges of BMI, and then the range which goes towards the red zone, which is now talking about the obese, clinically obese, and dangerously obese, have always been found to be at a higher risk for developing OSA. But this is one single factor. There can be other factors in females, such as menopause. It is gender linked, it is age linked, and again, there has been found to be some genetic predisposition as well. So this is basically what happens when we wake up with sleep apnea. So you have frequent urination problems, daytime sleepiness, loud snoring. It can lead to weight gain, moodiness or depression, headaches, impaired memory, or night sweats. So these are just some of the problems which can result from sleep apnea. And long-term sequelae, again, it's very serious in terms of long-term sequelae such as cardiovascular diseases, metabolic problems, neurocognitive effects, endothelial problems, and psychological effects. So these are just the long-term sequelae, which is the reason why we would like to address this. But I have always felt the approach to address this was wrong, which I will also talk a little bit about in the upcoming slides. So just to talk a little bit about the prevalence, current prevalence rates, ranges just if I'm talking about children, probably 1 to 5% worldwide. That means one The serious part of this is like one in every 100 or maybe one in every 20 children might be affected globally, which now suddenly becomes a very serious affair. It's again in certain special populations such as Down syndromes, people facing obesity as a disorder. It's just been shown to have a higher prevalence. So again, another serious point here is studies published before 2014 showed somewhere between 3.3 to 9.4% of prevalence, whereas studies post that time, specifically 2016 to 23, have shown a much higher prevalence. It's in some areas it's almost doubled, which has gone from 12.8 to 20.4% when you exclude the outliers. But now let's talk about the adult population. So again, you can see in Europe it's about 5%, Africa it's about 6%, 3% in Asia, North America 4%. So no matter where we are, this percentage is still a very big part of our population which needs some form of assistance. So again, one of the common confusions or some things that we normally link with OSA is snoring. So there are, let's say, 12% of children who were. So this was published by Connecticut Children's Hospital, where they found that snoring, only one in three children with snoring has OSA, maybe sometimes even lesser. And for the adults, it's if snoring is a 20% rate, OSA is about 4%. However, the problem is mostly diagnosing OSA out of those patients who are snoring, or or those patients who have associated symptoms as well. So currently, what we follow is polysomnography. I'll shed a little bit about light of about that as well, which is expensive and inconvenient. So just to give you a brief idea, in Cambodia, a sleep test or a polysomnography test would cost somewhere around $4,000 to $5,000, which is an expensive proposition for a lot of people. So again, why does the upper airway matter, especially me being an orthodontist? Again, we've seen researchers in the past which have seen that there's one genetic linkage as well as it has an impact on the growth itself. So these children are more predisposed to developing a long face syndrome, posterior cross bites, which makes the upper airway narrower again. There are patients who might have sleep related disorders, which again affects long term stability of results. And then, for us, in terms of treatment planning, I think it's very important to just know if a patient is predisposed to sleep apnea or any such airway problems. So, for us, I think one of the problems which I realized was looking at the airway just in terms of treatment implications. So, for example, we always look at patients in terms of extractions, non extraction. One of the I think I'll show that paper as we go a little bit ahead, was a very popular paper which was published in the scientific reports, if I'm not mistaken, talking about the effects of on the airway pre and post treatment for bimaxillary protrusion with extractions. So again, majority of the problems I've always seen in this area is because we look at results for a specific patient in terms of pre and post treatment, or we are more focused on the outcomes rather than the diagnostic aspect of the airway and its linkage with OSA itself. So, when we check for what should we check for clinically, just evaluation of soft tissues, including facial contours, functions, tongue, the tonsils, adenoids, polyps. But again, the pharyngeal airway is an intricate and a complex structure because we can carry out a number of activities. So, it should give you a rough bit of an idea of how complex that structure is. So again, in terms of the AAO guidelines, uh, there were two very important posts. One, which is in the Ajodo, which was a white paper which was published. So again, it highlights the issue of sleep apnea having many serious consequences if left untreated. Orthodontists should consider incorporating OSA screening for patients, and when OSA is suspected, the patient should be referred, and the definite diagnosis should be made. There is another recent post which was there, I think, in 2024, which I'm not mistaken, on the AO website, which talks about breathing easy. and how orthodontics can alleviate sleep apnea due to malocclusions by providing some appliances, by referrals in cases of severe cases. So, again, there is a very big area of work which has to be still done in regards to sleep apnea. But again, I think a lot of the appliances are focused on just maybe expansion because they think expansion is the only problem. Whereas, again, I'm trying to highlight again and again, there are different areas in the upper airway. So it can't be one solution to fix it can't be like one fix all approach. So this is literally the entire extent of the airway that we talk about. So again, there are different areas. If you look at this scientifically, there are you can look at this from a physics point of view. You can look at this from a biology point of view. You can look at this from an analytical or a maths point of view by measuring. So there are different views of looking at this. So currently, what we classify sleep apnea is either obstructive or central. Obstructive is what we are more focused on because it talks about partial or complete airway collapse during sleep. And this is the most common form, which affects about 2 to 9%, or as the data I just showed you. So, probably that suggests how we look at sleep apnea in terms of management across dentistry or orthodontics. So, we have different types of clinical assessments and screening tools. I'll go over these a little bit, and then again, I'll talk about the shortcomings of these approaches before I go towards the AI model. So current methods, we have lots of methods which keep on coming. So I'd like to highlight some of them. So our current approaches are, let's say, the first is again based on the apnea hypopnea index. I will demonstrate the values after this. We also have polysomnography, which today is considered the gold standard in terms of diagnostics, but is expensive. And again, we focus on the treatment part, which is expansion, removal of tonsils, and so on. And these days, we also have latest approaches such as MRIs, biomarkers, and so on. So the first one is the acoustic reflection technique, where it's somewhat similar to the sonar, which is used by submarines and ships to try and find out where there could be an obstruction. We project sound waves, and then these are reflected back out, so we can try and quantify changes in the airway cross-sectional area. But again, if you look at these approaches, I will keep highlighting the fact that these are unidimensional and they're always thinking about the problem from one aspect. Then we have the gold standard, as I so said, which is polysomnography, which records patterns of sleeping and breathing together. These days we have the option to do this in a hospital, and then the lesser accurate version, which is the home sleep tests. So we have a series of different tests such as EEGs, electromyograms, electrooculograms. We measure the airflow, the thoraco-abdominal movement, as well as oxygen saturation. So again, it keeps highlighting the fact that again we are thinking just about sleep. Whereas, uh, again, sleep can be very helpful. It can reduce our stress. It makes sure we stay at a healthy weight. It lowers our risk for health problems. It makes sure we just work normally on a day-to-day basis. But again, there has been research which talks a little bit differently about basal sleep needs versus sleep debt. So again, I like to highlight the fact that I don't think all of us eat the same amount of food, drink the same amount of water. So you might specify minimum sleeping hours, but again, everyone has different sleep needs, basal sleep needs, which is required for their optimal performance. And then the people usually suffer from sleep debt, which is what they accumulate when they don't sleep properly, one of the causes of which could be sleep apnea. So, then talking about the polysomnography or the gold standard. So, I just mentioned the tests, but I will also talk a little bit about the AHI or the apnea hypopnea index. So, this has been one of the most comprehensive tests. Again, I'm not disputing it, but again, it's expensive and probably not applicable for every patient. So when we look at AHI, there is a there are different ranges. So 0 to 5 is considered normal. So these are basically the events which occur when we are sleeping. We call these apnea hypopnea index. So when there are milder events, you can have a milder form of sleep apnea, you can have a moderate form of sleep apnea, but more than 30 events in one sleep cycle is usually considered severe. So, according to the ISD classification, which is one of the more comprehensive classifications or the first set of diagnostic criteria which was established, the patient has sleep deficit or sleepiness, non restorative sleep. It is one of the diagnostic criteria. The patient might wake up with holding their breath, gasping, choking, might be another criteria. Somebody or their partner might report that the patient has habitual snoring, breathing interruptions, and also associated with other systemic disorders such as hypertension, coronary artery disease, diabetes, and so on. So these are usually some of the important criteria which are used to classify. Then again, I'd like to keep highlighting this diagram as and when possible. So these were two of the papers which I wanted to highlight. So again, these are very good papers. There is no disputing that these are very high quality papers. But if you focus on both, they are again talking about the implications or the treatment outcomes of a specific study. So one talks about restoring the airway. Another one is talking about an extraction-based treatment plan for adult class 1 BIMAX patients. So again, we are more focused on the outcome of a specific treatment procedure, a specific technique, rather than having pilot data which can be utilized to have a definite diagnostic set of records. So again, if you look at this scientifically, because we were talking about fluid dynamics, so again, there are different kinds of flows. There can be turbulent flows in some region. There can be laminar flow in some regions. So if you look at this, the more we talk about this, you'll realize each one of these methods is probably good at one point of view, but it's probably deficient from another point of view. So as I said, you could talk about this from a physics point of view, mathematical data point of view, and in terms of clinical examination, which is lacking in the other points of view. So since we mentioned clinical examination, I also thought of highlighting clinical examination issues. So our current, again, our main methods of visualizing the airway, nasopharyngoscopy, sleep endoscopy, as well as advanced imaging techniques such as CT scans, MRIs. So, again, these are looking at a problem from probably one end. So, a nasopharyngoscopy can be very useful in detecting any problems in the nasal cavity or the pharynx. A drug induced sleep endoscopy has found to be a little bit more reliable using conscious sedation, trying to mimic the patient's natural sleep pattern in a clinical setting. And then we have the imaging records. Then we have the current standard of clinical examination, which is the Malampati classification, or rather, it's the modified Malampati classification which we employ. The original one was meant for airway intubation in burn patients, but we have the modified version which divides the risk into four categories. So this is one
Bro, ang dami.
classification. I thought I'll show you this visually. So class one talks ab- you can see actually the complete pharyngeal area. You can see the soft palate, the pillar of fauces, the uvula, the tonsillar pillar. But you can see as we keep going up in the classes, there is lesser of the view when the patient has maximal mouth opening to see the other areas in at the back. So you can see class 4 and class 3 are probably the more severe variants. So this is one of the problems that we've seen clinically, but again, it would be very useful to have more data to back this up. So these are, when we talk about, later when I show you the models that we developed. So one of the reasons why we thought the skeletal profiles could also be impacting the airway was we've seen different kinds of signs such as the Liao's sign, which you can see a flatter upper lip suggests a retrudent maxilla. There is the tongue bulge from deficient jaws inside impaired mouths, and there is the humpback from the head extended to open the airway. So we saw that there is some definite correlation And I will highlight this when we go towards the AI models that we developed. And a newer method which has come up, which is the Simmons chin press and tongue curl, the SCPTC method. It's again a bedside maneuver, which is again meant for sleep apnea diagnostics, and this is very valuable when you already have patients with with the diagnosed apnea already, or patients who have a serious deficit. So the latest protocols, or the stop and stop bang protocols, or the questionnaires. So this is more on the patient's symptomatic side. The stop questionnaire talks about the patient's symptoms such as, do you snore loudly? The patient or their partner could respond to some of them. Does the patient feel tired or sleepy during daytime? Uh, has anyone or their partners observed breathing cessation during sleep? Or do they have hypertension as well? And then we had another Bang enhancement, which talks a little bit about Bang essentially stands for BMI, age, the neck circumference, and the gender. So we also add some more factors so that the data becomes a bit more comprehensive. So if the BMI is above 35, which would be almost severely obese, age above 50, the neck circumference above 40, and if the patient is a male. So these would again have a higher risk or of being predisposed to OSA. So the current screening process includes all of these, which is the questionnaire, the Malampati scoring, as well as the symptomatic assessment. And then these days we have the home variant, which is the home sleep apnea testing. So again, I find this lesser reliable, but then it's easily accessible for a lot of patients, and it's much more cheaper compared to the clinical variants. So these are portable devices. I'll show you an example of a portable device as we go on. These measure mostly, not all, but just some of the parameters such as airflow, oxygen saturation, heart rate, as well as respiratory efforts. And it was basically meant as a cost saving exercise. So this is the timeline where the patient picks up the device, the patient sets it up themselves at home, the patient returns the device to the clinic, that data is downloaded and reviewed by a clinician, and then the patient normally meets a sleep physician to discuss what has to be done. So there are both pros and cons of home sleep testing. One, the accuracy itself, because at-home tests are not as accurate and as comprehensive as the polysomnography. There is always a risk of equipment malfunctions, and again there is limited data, again much lesser tests when we compare it with the clinical counterparts. It's just meant to be more comfortable and more convenient for the patients to be able to use at home. Then we have the latest studies, which are the dynamic MRI studies, which can give us an idea of the quantitative airway measurements and tissue characterization, treatment response. And these days, we are also going into biomarkers such as serum inflammatory markers, oxidative stress indicators, and disruption of the metabolic pathway. So again, this is just to show you the MRI comparison between a normal airway as well as an obstructed airway. So this contrast tells you a little bit about how the airway can be viewed much better using dynamic MRI imaging. Then these days we have lots of wearables, as you can see. Some of the examples of these wearables are uh, the wearable smartwatches. These usually come as form of as part of the kit, which monitors the heart rate, the airflow, and so on. We also have these patches which have come up in recent times, and we have this whole apnea test kit. So again, I have no financial implications, but I just wanted to show you an example of one of the home test kits which are available. And what this monitors, also it gives us some data on whether the patient is when is the patient in a deep sleep, or different kinds of sleep analytics. So one of the ideas which we had was to again integrate assessment for optimal management, or try to think of how a lot of these data could be combined for a more comprehensive workflow. So as I mentioned at the start of the presentation, our whole problem all this while has been that we focus on only one of the aspects of airway assessment, which is either the clinical history or visualization or physical examination or screening tools or sleep studies. Whereas an integrated approach or probably a collection of this whole data would have been more useful, because then we have a lot of analytical data to try and find out. This could be probably more of a problem. We also realized this when we were developing the machine learning models. We found out that uh, there is again a shortage of data that we could also improve on. So again, just to conclude this, this is what we talk about in terms of the anatomical foundations, the detection as well as the diagnostic excellence of what we are currently doing. But there are too many problems with conventional diagnostics. One is the cost itself. The second is the accuracy of this data, because you can see there are different, not every modality is as accurate as the other. And also there is a lack of predictive abilities, which is what we realized was a major problem. So just to show you what I think of what we currently do is probably somewhat like this, where we have a problem, and we are all looking at different kinds of solutions, whereas it could be much easier if we had a structured approach. So where do we come in and how do we think about this differently? So again, I've tried to always highlight this in different work that I've published, talking about the consistency of orthodontic decisions and what we promise our patients in terms of treatment outcomes. So again, we past research has shown that there is lesser consistency in our decision making, whether it's extractions, whether it's expansions, and it was actually seen that there is more consistency at the residency level. But as we go on, our experiences influence, or our emotions influence a lot of the decision making process. And also we tend to overpromise at times in terms of again, expansion being the one size fits all approach for OSA. So again, I think what I've seen mostly is this as a problem. So there was no final conclusion in the attempt to establish a cause and effect relationship. So sometimes we talk about fat, we are talking about different factors. So which is what one of the deficit of this whole exercise has been. So in terms of our decision making process, we always look at probably in enhancing the patient's quality of life, looking at good proximal occlusal contacts of teeth, and establishing a normal function. But orthodontics has evolved, moving in a number of ways from where we were a number of years back, from a hard tissue to a soft tissue paradigm. We are looking more at soft tissue profiles right now. There have been a lot of diagnostic techniques which have evolved. We are looking at the airway right now, which was not there. And again, there is also the advent of AI. So again, we have different levels of AI. We've had the machine learning models, which still rely on supervised learning, and then we have the advanced deep learning models, which again require lesser of supervision. So why we use AI? Because again, it's been incorporated in almost every sector now, from chatbots on hospital pages to airlines to banks. You can see it's there in every sector, because it can mimic the intelligence of humans and help us in the decision making role. We've done a number of systematic reviews that we've published in different journals, talking about the accuracy of AI in landmark detection. We've developed quite a few AI models across different problem areas that we could find. So what we found out was AI is very efficient at certain roles, such as examining data, collecting data, organizing and cataloging that data, which can be analyzed further. So our major problem is when we have multiple volumes of data, sometimes it just becomes difficult to try and correlate things together. So again, AI can help us. We have a different number of applications, umpteen number of applications which help us with automated landmark detection. within less than a minute. We have uh, AI applications helping us in extraction decisions. There are applications which give you the extraction index, taking into account the overbite depth indicator, the anterior posterior dysplasia index, and also there are applications which are helping us consult patients with surgical planning by showing them this is how they would look after. So when we're using it for so many purposes, why not try and see if we can use it for airway assessment as well? So again, we have, as I mentioned, we have machine and deep learning algorithms. Then we have some of the features which are very useful. One are CNNs, which are very good at image recognition, and then there is the automated feature extraction, so which can again help us identify certain anatomical landmarks. So for this purpose, CBCTs are very useful these days because these give you very comprehensive 3D images. These A lot of the new softwares are working with AI, so which helps us, such as Dolphin. You can see Anatomage. They work very well with CBCT integration, and the time there is almost 80% to 90% reduction in the analytics and much more consistency in measurements. But again, there was a paper which was published in the European Journal of Orthodontics, in which they had a number of assessors. They had, I think, six assessors. They had 10 patients who had multiple CBCTs, and they again found out that the reliability of the upper airway assessment was not reliable. So, again, there are a number of things which have impacted our data. However, there was another study which was published in recent times, which was using DiagnoCat, which showed it's very good in terms of AI segmentation, almost 94.7%, with a time reduction of 85%, and it was validated across 12 different devices. So again, I like these images a lot because these reflect what we are trying to do, but sometimes they're not so valid because you see the tooth without roots, but it looks very good in terms of AI images, which actually doesn't represent much. But then these are some of the research highlights which we've seen currently in terms of AI. So one is the sensitivity specificity is very high. Segmentation performance is very good, as I talked about the DiagnoCat study, and even in terms of efficiency. Some of these are very good, but I'll talk a little bit about the efficiency of different AI models as well. But our limitations are mostly these are focused on either single center data sets, and there is a lot of variability in the level of CBCTs, the imaging protocols, patient positioning, and so on. So as I said, again, there is always too many limitations with any kinds of methods. And then what we basically, if we do multicultural studies, there's a lot of data privacy concerns. So, in terms of diagnostics and imaging, what we focused basically was to develop a supervised machine learning model. In fact, we developed seven machine learning models using different landmarks. We realized one of the shortcomings of previous CBCT data was that they were looking at data from probably one point of view, but we realized we needed to also take into account linear data, volumetric data, look at the patient's profile, look at different factors, and try and find out what could be more correlatable. So again, we chose machine learning because for the initial models, it's always better to go with machine learning, probably take up deep learning in the future once we have enough volumes of data. So our idea was, as I said in the beginning, try and segregate the airway across into different areas for accuracy purposes, for measurement purposes. So we took out volumetric data from the CBCT. We also extracted linear data from the CEFs. And what we thought was one of the problems always with developing AI models is that we don't look at the consistency of data or what data is more relevant to building the AI model. So we decided to split this into two parts. One, the first part was the landmark identification, data collection, and analysis. The second would be to develop the predictive model, or rather, seven models and check their accuracy. So the first part was again, it was published in BMC Oral Health, which was the retrospective analysis of the upper airway anatomy. We also took into account Sella Turcica morphology because we were just looking at different factors to find out if there are definite correlations or not. So we had very specific data collection requirements, which is 50 CBCT records of each class, subdivided into 25 males, 25 females, and we classified these from the lateral cephes into class 1, class 2, and class 3s using the A and B angles and so on. So these were some of the landmarks which we measured. So you can see there were certain volumetric measurements of the different areas of the pharynx. There were linear measurements of different distances uh, for the length of the soft palate, the tip to the posterior wall of the pharynx, from the epiglottis to the posterior wall of the pharynx, and the sella turcica values as well as the volume. So because we wanted to check which of these parameters had higher correlatability, so what we did was we used MATLABs and we used cluster analysis to find out uh, which of the data had more stronger correlations. So we found out that class 3 individuals had a reduced airway volume in the nasopharynx, whereas class 2 individuals had a diminished airway volume in the hypopharynx, and there was lesser correlatability with the distance from the epiglottis tip to the posterior wall. And again, sella was found to be a less reliable factor because there was a very diverse and scattered spread. So I'll show you some of the data from the clusters. So when we analyzed the different clusters, we could see definite clusters for when we computed the hypo and nasopharynx for class 1, 2, and 3. We also had definite clusters for oro versus nasopharyngeal volumes, but we had very diverse scatter for, as I mentioned, one of the factors was the epiglottis tip versus the soft palate length, which meant this could not be used a factor to build the model. So once we concluded this part, then these were the major observations. We found consistent correlation between the cella length and depth, but we found different volume discrepancies. So now we decided to go to step two, which was to build the AI models. So we developed 7 AI models, all the common AI models, and we used 5 full cross validation. We also used a lot of untrained data, so we had to replicate our data collection again now, where we had a large number of untrained data, and then we had about 150 untrained data for cross validation. Again, this was published in BMC, which is the development and validation of predictive models. So these were the methods which are again available in the paper as well. So we isolated the 3D models, we measured these, and then we developed the 7 AI models, which is decision tree, random forest, gradient boosting, SVM, KNN, logistic regression, and neural networks. And we used this was built using up the Python language. One of the points which I wanted to highlight here was the confusion matrix. So the reason why I brought this up was most times we see a lot of AI models being published right now. But one of the problems is with the validation of these AI models, we use very less untrained data sometimes. So it leads us to different problems. In terms of the seriousness, let's look at what the confusion matrix tells us when we cross validate these. So we what we want is ideally more true positives and more true negatives, and lesser false positives and lesser false negatives. But if your AI model is not very accurate, you would see a higher percentage of false positives and false negatives, which we want to avoid essentially. So for an AI model to be remotely predictive, it should be at least 70% and above. So when we tried to test, we kept on doing our cross validation. We finally reached back accuracy levels of 74% on random forest, and eventually we able to, when we increased the sample of untrained data from 90 to 150, we reached random forest accuracy of 80%. Again, I like to take this result in a positive way, but also with a pinch of salt, because that means there is 80% accuracy, but that means there is still 20% more accuracy that we need to improve on. So across both genders, we had 75% accuracy. So what we want at some point in time is to have a fully integrated AI workflow where we combine a lot of different data, we do real-time monitoring, and then we develop deep learning models which can keep improving in terms of accuracy. So because we realized the shortcomings of our first project, which was only taking into account, as I said, one-dimensional data. So our new project, basically, we've started is based on collection of CBCT data, lateral ceph data, the stop bank questionnaire, as well as the clinical examination. So right now, this is currently underway where we have again, we've started off with the sample size of 30 for each class 1, 2, and 3, and then we'll keep increasing the sample size as we get the results from the initial analysis of the data. So this would probably follow the same workflow. We have just initially started this approach since, I think, maybe about 6 months ago. So hopefully we should have more data to show in the near future. So just to probably heading towards the end, we have lots of emerging technologies, talking about 3D printing, robotic integration, VR. So we've developed a number of VR, AR models, but it's again less efficient right now in terms of us being able to visualize and measure and look at problems itself. And again, a predictive modeling which will improve. So our whole idea is to probably look at the next frontier in airway orthodontic care, look at how we can converge, offer better uh, services and better treatments to our patients. So AI has had a transformative impact, especially with us in terms of how we look at data, how we can analyze that data for different purposes. We've already managed to reach in a lot of projects 80 to 85% accuracy, but again, in terms of patient outcomes, it still means that there are 15% patients who need that improvement as well. So we always have to constantly look at how we can improve these models by adding more data. So more data quality as well as quantity of data is always very useful. If we have a very good quality of data, that goes a long way in helping transition our research. So again, AI has the potential to be a game changer. And again, what we found out from our work was that random forest was the most, because it employs a multiple number of decision trees. So it was found to be more accurate. But again, I think since we are developing more, collecting more data, so in time we should probably see more accuracy for the models that we keep working on. So I'd like to conclude by using a quote from one of the Stanford experts who said that although orthodontia recognizes the importance of evaluating and treating upper airway sleep disorders, they are yet to realize how well positioned they are for prevention of sleep disorder breathing. So I would like to thank Professor Christian Guilleminot from Stanford for this quote. And thank you so much for listening. And I'm very happy to have any discussions on this. Thank you so much.
Thank you so much, Professor Maria, for this amazing presentation, and also for walking us through the upper airway assessment and then even to the evolution and also the AI aspects of this topic. So now, at this time, I would like to invite our panelists for some panel discussion. So first, I'd like to invite Professor Cha for some comments. Professor Cha?
Hi, yeah, it was great presentations, and I agreed Dr. Meyer presentation because he pointed for the combination of clinical examinations, imagings, and patient history rather than relying on the single diagnostics method. So he applied his AI technology in this field. So I'm very interested in his ongoing research, and he found some outcomes from his models, and he's currently still doing right the combinations with the clinical data, right, questionnaire and anatomical feature. So at this time, if you have any ongoing outcomes, can you share about your recent research on applying the combinations between your data and the clinical examinations.
Yes, please, Professor. Thank you so much, Professor Janil Shah. So, Professor, we realized the shortcomings of our first round of studies. It was a 5.5 year project, which took us a lot of time just because of the specific data that we needed. But because we saw shortcomings in that research, we were able to cut down a number of factors which we wanted to implement for the second stage, which means, like, for example, there were some of the linear measurements that we could isolate, and we removed it from our second round because we found they were much more diverse and not so accurate. So now our second round, we have noticed when we look at patients specifically, again, I think we modified from the stop questionnaire to the stop bang questionnaire now, because we thought, again, the stop questionnaire was just symptomatic, but then we added the bang part, which is to record the patient's data as well. Now we've actually found a higher correlation between some of the patients who've reported symptoms, also in terms of their clinical presentation. But we also found one of the interesting phenomenon was not everyone had a history of systemic disease, or they actually had not been diagnosed yet. So in a way, it's helping patients probably realize, or go into physicians for checkups as well.
So you mentioned that the polysomnography is like a gold standard for the diagnosis of the OSA. So using prediction model for the future from your research, um, can you imagine we can diagnose the patient's disease without polysomnography? How about your opinion on that? Then
Please.
it'll be possible. It really a fantastic method, right?
Please, Professor. So again, thank you for your question. So I think, again, I'd like to clarify at this point, our idea was not to replace polysomnography, but it was to probably lessen the burden that we put on polysomnography. So for example, rather than subject every patient to $4,000-5,000 tests, if we could, with reasonable accuracy, identify at-risk patients, those patients should be the ones getting polysomnography, not so many patients. So our idea was to have, this is what we started out with, was to, right now, with our predictive models, what we need to spend is about somewhere between $70 to $100 for a good CBCT, and basically that's the initial expense for a patient. So when once these patients find out now they're at risk, these patients can go in for further testing and see if polysomnography is viable for them, rather than seeing 100 patients at risk and we refer them all. So we always thought of having us as an adjunct, but at some point, if we have enough data, probably we could think of this as a viable alternative, if not completely replace it.
Yeah, thank you for your comments. Yeah, I'm agreed with your answer. Yeah, thank you.
Thank you, Professor.
Okay, thank you, Professor Cha. Next, I'd like to invite Professor Santuan for some comments.
Okay, first, thank you, Professor Anand, for such a detailed and insightful presentations. Let me ask you some questions. I noticed that your model performed differently across the malocclusion types, right? What do you think drives that difference?
Please, thank you so much, Professor. So, Professor, I think the differences that you saw were mostly in terms of the data first, because different kinds of malocclusions have different parameters, or which was our whole idea, to find out a definite correlation between specific malocclusions and their pharyngeal data, specifically with regards to the oro-naso and hypopharynx. So, since all of them had reportedly different measurements, so when we carried out the cluster analysis, we found that was the whole idea, to refine the quality of data we input into the machine learning models. So which is why we carried out this whole exercise. And it has been seen in research, even if we look at normal Cephs, we look at class 2s, class 3s, there is always a relative discrepancy between the maxilla mandible, but we're never able to correlate it with the measurements of the airway, which is why we carried out this exercise.
And if that's so, do you think that it may change how useful the tool might be for certain type of patients?
Yes, please, Professor. Agreed completely. So again, this was our idea when we started out. As I was answering Professor Jungil Shah as well. So our idea was to look at data from a different perspective, whereas right now we just use it for treatment planning, which means this is what we do in terms of extraction, non-extraction. But if we could use the same data for enhanced diagnostics, I think it helps serve our patients better.
I see. So my third question is, have you thought about using model that works directly on the three-dimensional CBCT scan instead of you just relying on the landmark measurements?
Yes, please, Professor. So actually, we were trying to look at the data from some of the softwares right now. So again, if you look at some of the softwares, they are also trying to isolate. Basically, they're trying to just isolate the linear measurements and construct the airway. So if you look at Dolphin and Atomash, they are not essentially reconstructing the entire three-dimensional way. What they do is just isolate the outlines, and they just use linear data, which is why we thought to just enhance the quality of data by having both volumetric and linear measurements, not just rely on linear data to compute the 3D volume. So which is why we developed the DICOM 3D models and carried out the measurements on the 3D models instead of just extrapolating the points using the linear CEFs.
Okay, thank you very much.
Please.
Thank you, Professor Santuan. And next, I'd like to move on to our Q&A session. So the first question is from Dr. AB, and the question is it possible to determine if the patient has airway problem from cephalometry, and how do we identify this type of problem?
Yes, please. So I think this is probably just an extension of the question Professor Santivong asked as well. So again, if we look at the airway, which is three-dimensional structure from just in terms of linear data, that has always been our problem in terms of identifying airway problems accurately. So you can actually import it into some of the softwares like WebSEF. They would give you a rough idea. I think even Vatek, the new generation, does give you an airway analysis using the CEFs as well as CBCTs. But then again, that would not be very reliable, which is the reason why we have to look at more multinodal data as well as more comprehensive data.
Okay, thank you. And our next question is from Dr. Sonia. And the question that she has is, what are some AI apps that you can use for diagnosis and treatment planning for orthodontics? Or if you have any programs or freeware.
Yes, please. So again, I'm happy to name some. Again, I have no financial implications, but we have WebSEF, we have YSEF, you have, these are just to name a few. You can, for example, WebSEF, it's a very comprehensively used software, which you can use for free. I think it has some advertisements which are linked to it if it's free usage, but you always have the access to use it, the option to use it for paid access as well. Uh, but it's been found to be very accurate. It was one of the softwares which we did analyzed in the systematic review as well that we conducted, and it's been found to be almost 92 to 94% accurate in terms of uh, uh, not just the diagnosis but even treatment planning in terms of using the extraction index and the interpretation of the extraction index itself.
Okay, thank you. And actually, right now, I'd like to invite our third panelist, Professor Clement Lin. Professor Lin, would you care for some comments?
Thank you very much, Dr. Marya. And recently, in our country, we have a hot issue about there was a dental doctor that raised a question that maybe the orthodontics works can compromise the airway in growing kids or child or even the adults. What's your opinion about this part? Because in the orthodontic works, there might be a lot of extraction and retraction of teeth. What's the impact on this works on the oral cavity and the pharyngeal airway?
Please, thank you so much, Professor Lin, for this question. So, Professor Lin, actually, again, if I just go by, which is, I like to always use scientific data as evidence. So, we've had a lot of research done which has shown that, let's, for example, an extraction case, the amount of decrease in the anterior posterior volume is actually compensated enough by the transverse expansion when we carry out orthodontic treatment, so which is actually more. So there is not going to be a deficit just because of extractions alone. But then there are, as I mentioned, I think during the course of this presentation, the main problem is just looking at expansion extraction as a problem, whereas we have the posture of the tongue, we have the anomalies itself in the pharyngeal area, which we so if we look at one dimensional treatment which is just using, even Marpe has not been found to be that effective in certain situations, because probably that was not the cause of the sleep apnea. So I think for me, the problem is not the extraction versus expansion debate, but I think it's us not focusing on the diagnostics itself and having data comprehensive enough to take those decisions. I think this is what I would like to answer without raising a controversy, probably.
Thank you very much for your answer.
Please, Professor.
Thank you, Professor Lin, for your comments. So now let's return to our Q&A session. And our third question is from Dr. Panthy. And the question is, how do you decide whether to extract or to improve profile, or defer the extraction and compromise the aesthetics in bimaxillary cases? So in short, how do you balance between aesthetics and function?
Yes, please. So again, thank you so much for that question, Dr. Junior. So again, we have a number of diagnostic criteria when it comes to making extraction decisions. So specifically, Bimax cases would usually have an increased IMPA, increased ANB angle. If you look at soft tissue aesthetics, usually the lower lip is beyond the E line. So these are some of the factors which we look at improving when we are making extraction decisions. When it comes to, I think the probably the only cases where I won't decide to extract is if the patient has a macroglossia. So now if the patient has an enlarged tongue, we are extracting and retracting. Those are probably the only conditions where you're bringing the teeth closer to the problem area, so there's a higher degree of relapse. But otherwise, most other cases we should not have a problem deciding between improving aesthetics, restoring normal function, because in terms of orthodontic treatment planning, if you look at Jackson's triad, we have to restore both, as the patient's concerns are usually aesthetic, but the orthodontist's responsibility is to restore both aesthetics as well as proper function.
And also, just out of curiosity, are there currently AI programs or things that can help you to kind of tell you the percentage of relapse or the rates of relapse that might occur with these cases? Does it account for the chances for those?
No, there have been a lot of researchers which have compared pre and post data to show certain cases have a higher degree of relapse. Because let's say like open bites have always been known to have a higher degree of relapse, but it's again because of people wanting to just extrude the centrals rather than look at the problem, which was the extruded posterior segment. So I think it's more to do with uh, probably faulty diagnosis where we have a higher chance of relapse. But currently it's very difficult to build an AI model for this, just because the amount of data required to build something with reasonable accuracy would be too much. So we have different malocclusions, different profiles, different treatment plans, so it's very difficult to, AI models work best when you have a specific question which can be answered.
Okay, and our last question is from Dr. Patrick Chen. And the question is, what's your advice for a unit who hasn't started using AI in their analysis and assist with decision making? And how would you recommend them to start?
Yes, please. Again, thank you, Dr. Patrick. It's a very important question. So again, I am just looking at that data from an AI perspective, but then these are the three or four important uh, kinds of data, which is the clinical examination. You can start with already. You can just add it to your current diagnostic forms in terms of incorporating the Malampati classification. You can incorporate the stock bank questionnaire, so these will at least help you identify at risk patients. So now this helps you a little bit in terms of the treatment planning, not so much in terms of the CBCTs right now, or probably the airway analytics. But since you don't have AI facilities, or that's what your question implies, I think a good method would be to just start off with the stop bank questionnaire as well as the clinical examination. That should serve you well in terms of initial diagnostics itself.
Okay, and that's the end of our Q&A session. So thank you to all the participants that raised questions. And also thank you to Professor Maria for the answers. And let's ask PY for the conclusion of this webinar.
Thank you, Junior, and thank you all panelists. Especially, I have one question for Professor Maya. As I know, I have read some of the journal and the paper about OSA as well, and we have a lot of image modality to evaluate, either the linear measurement or the minimal cross-section area, and or either the volume, especially the volume of the nasopharynx, oropharynx, and the hypopharynx. I have no idea. In your opinion, what is the most dominant, the parameters you will measure how severity of the patient with the OSA in the 2D or in a 3D measurement? What is your opinion? Thank you for this question. Thank you.
Thanks. Again, thank you so much, Professor Chow. So I think for me, I think the most dominant parameter was what we found out during the diagnostics itself. So now that we know what to look for in a patient with a class 2 malocclusion, with a class 3 malocclusion, in terms of a reduced nasopharynx, a reduced hypopharynx. So now it becomes, because our solution has always been okay. So if I have a patient with OSA, I use a MARPE. But then let's say your problem was much lower down, having a MARPE will probably increase the transverse dimension. So most times, if you look at the patients, they will just give you a symptomatic relief, or probably they might feel better for a while, but then the symptoms usually tend to return later. So for me, I always like to look at different parameters. One, because we record that data itself, so we try and get the patient to improve across different areas. So one is probably reducing their BMI to a safer range. I try to correlate it back with the CEFs. So now when you will notice, when the patient improves on different fronts, it also shows you some relief. So for example, my uh, if I'm using image-based classification, it shows you there's a reduced nasopharynx or a reduced hypopharynx. There is usually a lining of fat which runs there. So once the patient starts to lose weight, you will notice that the patients usually become better in terms of symptomatic relief. But then now, if there is an actual transverse discrepancy, now it becomes there's a better solution for with MARPE or SARPE. Probably it serves the patient better. So the reason why I feel the image-based data is not so accurate is just because it will just extrapolate to specific points. Okay, let's just measure the minimum cross-sectional area, but it doesn't give you the complete picture. So if you remember my slide with the cats, basically it needs a more
Yes.
structured approach. But if we look at data which is currently available with most of the applications, it doesn't give you very accurate uh, idea of the problem at hand. So we actually need to integrate that with everything else, which was our objective of building these models as well. We try to have a more comprehensive model. Hopefully in the coming few years we should have some solution for everyone.
Thank you very much. Yeah, thank you, Professor Maya, for your very comprehensive illustration of the OSA and especially in the AI field to figure out the further the solution to maybe the AI prediction for how severity of sleep apnea in the patients. And thank you for our special panelists. Professor Chang, Professor Sentiwang, and Professor Lin. I would like to invite all our audience and the participant to open your screen, and we are ready to have a group photo with our speaker and our special guest, 3 panelists. Professor Clement Lin, Professor Handa, and Professor Narisapong from Thailand. Hello, Jensen from Singapore, and hello, Anup. Okay, and I will count to 3, and please give me your big smile. Big smile. Thank you very much. Hi, Professor Cole. And 1, 2, cheese. Okay, thank you, all the expert for tonight and or this morning's presentation and very important discussion together. 2 weeks later, we have another presentation from Korean professors. Ben Yong Kim will give us a special lecture as well, and looking forward to your participate as well too. So thank you again, Professor Anand and Marya, for your great talk, and hope all of you learn and share the experience with your colleague and with all the international friends as well. Thank you for your time. See you 2 weeks later. Have a good day and have a good night. Bye-bye.
Thank you all the
Thank you so much.
Thank you, Professor Marya.
Thank you, Professor Handa. Thank you, Narisapon.
Thank you.
Thank you, and
See you.
Anup.
Yeah.
Thank you.
Bye.
Thank you, Professor Marya.
Yeah. Thank you, Marya.
Okay, thank you, Junior. Okay.
See you tomorrow. Bye-bye.
Yeah, see you. Bye.